Hello everybody, this is Dr. Tani Isa, Professor of Pathology. I make these videos for all medical students. Hope someone may find it helpful. Today we are going to talk about obstructive versus restrictive pulmonary diseases. So based on pulmonary function tests, chronic non-infectious diffuse pulmonary diseases can be classified into two big categories. The first is obstructive diseases and the second is restrictive diseases. So obstructive diseases means it is airway diseases and restrictive diseases means it is parenchymal diseases. Let's start with obstructive pulmonary diseases. In obstructive pulmonary diseases, there is an increase in resistance to airflow due to partial or complete obstruction at any level from the trachea and large bronchi down to the terminal and respiratory bronchioles. Is this obstruction or this increased resistance occur during inspiration or during expiration? It is mainly during expiration. It is expiratory. So let's see the symptoms of obstructive pulmonary diseases. So in obstructive pulmonary diseases, it is difficult to expel all of the air from the lungs. So the patient feels it is hard for him to expel all of the air from the lungs because there is increased resistance. And this becomes worse with activity because when the respiratory rate increases, it becomes challenging to blow out all of the air in the lungs before taking the next breath. Also, narrowing of the airways may cause wheeze, so the patient will complain of difficulty in emptying his lungs and also of wheezing. And he may need to use some medication to dilate the bronchioles, some bronchodilators. Inflammation of the bronchi also or bronchioles may increase the mucus production or sputum, and this causes cough, productive cough with sputum because of this increased mucus production. So the patient will also complain of productive cough. So in obstructive pulmonary diseases, so far, we know there is increased resistance to airflow. It is a problem of airway diameter, and there is shortness of breath in exhaling air from the lungs. So expiratory airflow obstruction may be seen in chronic bronchitis, bronchiectasis, bronchial asthma, emphysema, and small airway disease, bronchiolitis. So go to restrictive pulmonary diseases. Restrictive means there is reduced expansion of the lung parenchyma and decreased total lung capacity. So these cases occur when there is a patchy fibrosis of the lung, interstitial fibrosis of the lung. When there is interstitial fibrosis of the lung decreased in size because of contraction of the fibrous tissue. It decreases in size, and this fibrosis makes the lung rubbery or firm in consistency, and this leads to reduced expansion. This is called reduced compliance of the lung. So it is a problem of compliance of the lung or stiff lung. So what is compliance? Compliance means the ability of the lung to expand with air. So good lung compliance means the lungs expand easily. So stiff lung usually have low compliance and low volume. This may be due to several causes. Causes of restrictive lung diseases may be intrinsic causes or extrinsic causes or neurological causes. So intrinsic causes refer to those that occur due to restriction in the lungs. So the cause is in the lungs itself, often stiffening of the lung, and this include usual interstitial pneumonia, which is also called idiopathic pulmonary fibrosis. It is the same, usual interstitial pneumonia, or it is also called idiopathic pulmonary fibrosis, or non-specific interstitial pneumonia, cryptogenic organizing pneumonia, or it is associated with connective tissue disease, or cases of pneumoconiosis. In all these cases, there is interstitial fibrosis of the lungs. Also in drug reactions or radiation pneumonitis, granulomatous causes, maybe like sarcoidosis, hypersensitivity, pneumonitis. So in all these conditions, and eosinophilic granuloma, in all these cases, there is interstitial fibrosis of the lungs. So we have also extrinsic causes. In extrinsic causes, the causes are outside the lungs, but it affects the lungs. So it refers to those that originate outside the lungs. These include impairment caused by scoliosis, severe obesity, hypoventilation syndrome, ascites. In all these conditions, these cases affect the lungs, compress the lungs, pleural effusion, or even pleurisy without effusion, malignant tumors, rib fractures. In all these cases, the lesion is outside the lung, but it affects the lungs. It is extrinsic causes. We have also neurological causes, referred to those caused by disorders of the central nervous system that interfere with movements necessary to draw air into the lungs. Among the most common causes are poliomyelitis, also paralysis of the diaphragm, or Guillain-Barré syndrome, myasthenia gravis, and muscular dystrophy, and amyotrophic lateral sclerosis, or Lou Gehrig's disease. So, what are the restrictive symptoms? With restrictive lung disease, a person may feel like it is hard to take a full breath. It is hard to get air inside the lungs. It is difficult to take the air inside the lungs. So it is the reverse of obstructive disease. In obstructive disease, the patient feels difficulty to expel air out of the lungs. Here, the patient in restrictive disease, the patient feels it is difficult for him to take air inside the lungs. It is difficult to fill his lungs with air. It is difficult to take a full breath. See? And this may cause considerable anxiety at times. And with extrinsic restrictive lung disease, when the cause is outside the lung, the patient may change positions, trying to find a one that makes it easier to breathe. See, he will change position, trying to make it easier for him to breathe. Dyspnea and dry cough. Here is the cough is dry cough because this condition restrictive, the lesion is interstitial. It has nothing to do with the bronchi. The lesion is interstitial fibrosis. So the cough is dry cough. And hypoxia are main symptoms. Dyspnea, dry cough, and hypoxia are main symptoms. Also tachypnea, shallow breathing because of the low level of oxygen. The patient trying to make shallow breathing to increase the respiratory rate. It will be more than 20 breaths per minute. So, a restrictive pulmonary disease characterized by reduced expansion of lung parenchyma. It is a problem of compliance, not airway diameter. It is a problem of compliance and shortness of breath in taking air inside the lungs. Now, we have symptoms shared by both obstructive and restrictive conditions, and this includes shortness of breath, dyspnea, persistent cough, rapid respiratory rate or tachypnea, anxiety, and unintentional weight loss due to increased energy needed to breathe. These symptoms shared by both obstructive and restrictive conditions. Can a person have symptoms that suggest a combination of obstructive and restrictive disease? Yes. A combination of obstructive and restrictive disease may occur. For example, when a person has both chronic obstructive pulmonary diseases and also got pneumonia. And also some diseases such as silicosis can cause obstructive pattern in the early stages of the disease and restrictive pattern when the condition is more advanced. So go to morphology. What are the morphology of obstructive and restrictive pulmonary diseases? In obstructive pulmonary diseases, you see both lungs are markedly enlarged. See, this is a case of emphysema. You can see the lungs markedly enlarged, and you may see clusters of dilated air spaces. Here it is very evident, very conspicuous in the middle and lower lobes. These clusters of dilated air spaces compare with the normal, and it is also in the middle and lower lobes of the lungs. Histologically, you can, or microscopic examination, you can see the alveoli are very distended. Some alveoli, you can see the wall of the alveoli may rupture and broken alveoli like this. You may see bolli, it may cause also bolli. And you can summarize the morphology or gross pathology. The size of the lung is increased, the weight is increased, the color is paler because the dilated alveoli compress the blood capillaries, and the consistency is increased compliance. It is very spongy, it is very filled with air, and the cut surface may show ruptured alveoli or bolli, or it is very, very, very frothy. Morphology of restrictive lung disease. In usual interstitial pneumonia, you can see here interstitial fibrosis. The interstitial fibrosis causes scars, and these scars, as you see, retraction of the scars along the interlobular septa, give this pleural surface. This is the visceral pleura. It gives this surface what we call cobblestone pleura. This beautiful cobblestone appearance. Can you see this beautiful cobblestone appearance? This is because of this interstitial fibrosis. This interstitial fibrosis causes scars. These scars cause retraction along the interlobular septa. So it gives this cobblestone appearance. This is very characteristic. And if you go to the cut surface, you will see patchy fibrosis, and you can see here subpleural. Can you see this subpleural cysts? This subpleural cysts. This is called honeycomb appearance. This cysts. This because the alveoli are broken and they form these cysts. Can you see these cysts? This is the honeycomb pattern, characteristic honeycomb pattern. It is subpleural and basal. Very, very beautiful and very characteristic, this honeycomb pattern. This is also honeycomb pattern. This is interstitial fibrosis also. This is idiopathic pneumonial fibrosis. So the morphology will be, here the size of the lung is decreased size of the lung, consistency is firm to rubbery, the color may be grayish white because of the fibrosis, and the cut surface shows the honeycomb pattern, and the pleural surface shows the cobblestone appearance. So microscopically, we will see the interstitial fibrosis. The hallmark is the patchy interstitial fibrosis. This patchy interstitial fibrosis, as you can see early lesions and late lesions. The earliest lesion contain exuberant fibroblastic foci like this. Here also you can see, and the more collagenous area. You can see here, this is the early lesion. This is the early exuberant fibroblastic foci. Here is the fibroblast trying to form the collagen, forming the collagen. And here, after forming the collagen, it changes into fibrocyte. and you can see this band of collagen, and between the collagen bands you can see the flat fibrocyte. So it is very typical to see both lesions together, early and late. And also you can see this cysts, cystic spaces lined by type 2 pneumocytes or bronchiolar epithelium. Here you can see it lined by bronchiolar epithelium, and this is the honeycomb pattern. X-ray finding. What are the X-ray findings in obstructive and restrictive pulmonary diseases? Let's see in obstructive. Obstructive means the lung is hyperinflated with air. So the lungs are big and it compresses the diaphragm, push the diaphragm downward. So you can see flat diaphragm here. The diaphragm is flat. So you can see hyperinflated lungs, flat diaphragm, and barrel-shaped chest. And you may see bully and you may see pneumothorax. Sometimes in restrictive lung disease, here you can see the lung shrinks, and when the lung shrink, the diaphragm is high riding. You can see high riding diaphragm on both sides, and you can see these opacities due to fibrosis, and also you can see this soft ground glass opacities in the basal segment. This is called the ground glass opacities. So in restrictive lung disease, you will see high riding of the diaphragm and ground glass opacities. Compare with the obstructive. Here the obstructive lung is hyperinflated, pushing the diaphragm downward, and here the lung is shrink, and the diaphragm, there is riding up of the diaphragm on both sides. And compare with the obstructive, here you can see the mediastinum is narrow, but in restrictive you can see the mediastinum is wide and distorted, and there is increased opacity, and even the mediastinum is thickened. The above this may be because of cor pulmonale. You may also see the right side of the heart enlarged. Here is also increased shadowing. When you see this, it is restrictive or obstructive? Restrictive. You can see this fibrosis, this opacities. Here opacity, and here you can see also right side enlargement of the heart, and the diaphragm. You can't see that the diaphragm. You can see here diaphragm is not clear. Compare with the obstructive. Also in restrictive lung disease, you can see this honeycomb pattern, subpleural, beautiful. Here is beautiful honeycomb pattern. This is very characteristic, subpleural. In subpleural segment and in the lower region of all lobes, it is very beautiful honeycomb pattern. Go to pulmonary function tests. Pulmonary function tests. What's spirometry? Spirometry is a common office test used to evaluate how well your lung function by measuring how much air you inhale and how much and how quickly you exhale. So spirometry can be very helpful in differentiating obstructive and restrictive lung disease, as well as in determining the severity of these diseases. So we have to know there's something called forced vital capacity. What is forced vital capacity? This measures the amount of air you can breathe out forcefully after taking as deep a breath as possible. Forced vital capacity is normal in obstructive lung disease, and it is decreased in restrictive lung disease. Now, we have to measure this forced expiratory volume in 1 second, because in obstructive pulmonary disease, it may be normal or may be decreased little. So it is better to see the forced expiratory volume in 1 second. So in 1 second, so it measures the total amount of air that can be forcibly expelled in the first second of forced vital capacity. So I want to see how much air the patient can expel in the first second of the forced vital capacity. So what you expect? What do you expect? Who has difficulty in exhalation? The obstructive or the restrictive? The obstructive diseases. Good, very good. So about healthy people generally expel around 75 to 85% of this time. So forced expiratory volume in 1 second is decreased in obstructive lung disease, definitely, because those people have difficulty to exhale, have resistance to airflow, so it will be decreased in obstructive lung disease. In restrictive, it is variable. It may be decreased or may be normal, according to the stage of the disease. Now we make this forced expiratory volume in 1 second. We make a ratio of forced expiratory volume in 1 second over the forced vital capacity, and we see this ratio. This ratio is very important in differentiating obstructive from restrictive. So this measures the amount of air a person can forcefully exhale in 1 second relative to the total amount of air he or she can exhale. This ratio is decreased in obstructive lung disorders, and it may be normal or increased in restrictive lung disorders. This is because in restrictive lung, forced vital capacity will decrease. So in an adult normal ratio, it is 70 to 80%. In a child, the normal ratio is 85% or greater. So expiratory forced, this ratio of forced expiratory volume in 1 second over forced vital capacity ratio can also be used to figure out the severity of obstructive lung disease. Now go to total lung capacity. You know the volume of air, it measures the volume of air in the lungs after exhalation plus the forced vital capacity. So if you want to know the total vital capacity is the volume of air left in the lung after exhalation plus the forced vital capacity. So this is increased in obstructive lung disease and it is decreased in restrictive lung disease. We know in obstructive lung disease the total lung capacity increased and it is decreased in restrictive lung capacity. In obstructive lung disease, air is left in the lungs and air trapping or hyperinflation causing increase of total lung capacity. Other pulmonary function tests which cannot be measured by spirometry, we have something called functional residual capacity. This estimates how much air is left in the lungs after normal passive exhalation. So it is the reserve amount. Functional, if you want to know functional residual capacity, it estimates functional residual capacity is the amount of air left in the lung after normal passive exhalation. See, if you make normal passive exhalation, do you think that there is some air you can exhale? Yes, we have some more air we can exhale, and this is called the expiratory reserve volume. So the expiratory reserve volume is the reserve amount of air that you can exhale forcefully after passive exhalation. This is called expiratory reserve volume. Okay, so after this, we make passive exhalation and then we make more forcible exhalation to give the expiratory reserve volume. So, do you think that your lung is empty now? No, your lung is not empty now because you still have some air in your lung, and this is called the residual volume. The residual volume is the amount of air remaining in the lung after expelling as much air from the lungs as possible. The residual volume can never be exhaled, and thus it cannot be measured using spirometry, and it is the air causing the alveoli to remain open. So the residual volume you can never be exhaled. So after you make a forcible exhalation, very forcible, it is still there. The residual volume is some air which is still in your lungs, keeping the alveoli to remain open. Therefore, the forced functional residual capacity can be represented as the equation. So the functional residual capacity is the equation of residual volume plus the expiratory reserve volume. So, in restrictive lung diseases, the lungs are often stiff or less compliant, and the chest wall expansion are limited or restricted, and in restrictive lung disease, total lung capacity decreases, and also the functional residual capacity decreases, resulting in decreased functional residual capacity. With obstructive lung diseases such as emphysema, the functional residual capacity is increased. With obstructive lung diseases, it increased. So functional residual capacity, you will see it increased in obstructive and reduced in restrictive pulmonary diseases. In obstructive lung diseases, the lungs become increasingly compliant due to alveolar destruction. As the alveoli are destroyed, air is trapped in the lungs and total lung capacity increases. The increased volume and the lung tissue compliance causes the chest wall to expand and gives the characteristic barrel-shaped chest, which we see in emphysema. Thank you.